We talk a lot about population health, and we've got new tools, but there are still challenges in terms of their implementation. Cardiovascular disease accounts for about 18 million deaths globally. Most of those deaths are from atherosclerotic cardiovascular disease, and one of my area of interest is in lipid lowering. These are a list of my disclosures. So we basically think about cholesterol lowering for different levels of risk and throughout the life course. And what you don't want to do is overtreat low-risk individuals, and you don't want to undertreat higher-risk individuals. So gradually over time, what we've seen is that we've lowered the cholesterol goals or the cholesterol targets that are risk-based. So all assessment starts with a risk assessment, and then basically we move on to thinking about what is the appropriate target for those individuals. In Europe, between 2016 and 2019, largely because we've got data for add-on therapies coming through, the targets for moderate, high, and very high-risk patients were reduced. So in each of these categories, they came down by about 0.4, 0.5 millimoles, so about 20, 25 milligrams per deciliter. And you'll see on the right-hand side, in the two red boxes, the very high-risk and very high-risk groups, that 50% is an attempt to try and get you to optimize the dose of statins, so 40 of atorva, 80 of atorva, 20, 40 of Rasuva, and then aim for a goal. What's sort of slightly missed out is that to get to those goals, you're probably going to have to use combination therapy, and that's not implicit in the way that things are written. So one of the registries that we conducted between those two guideline updates was a Da Vinci study in 18 countries, about 6,000 individuals. And if you ask the question, when you use lipid-modifying therapy for those four categories, what's your approach? And if you add up the different boxes, you'll see that in Europe, the vast majority, 84% of prescribing, is with statin-based monotherapy. The use of ezetimibe in combination with statins is only 9%. And at least at that time, the use of monoclonals was only about 1% as an add-on. So what's the effect of that? Well, what we've done is we've changed the goalpost. The baseline cholesterol levels haven't changed. So when the goals were easier to achieve, with a monotherapy-based approach, 1 in 2 patients were getting to goal. But immediately, as soon as you change the goalpost, only 1 in 3 are getting to goal. So you're going to fail already before you've started in 60% of your patients. Now, on the left-hand side, we're basically now focusing on the 50% of patients that had ASCVD. We do a little bit better with the use of high-intensity statins here rather than moderate intensity. But remember, when you go from moderate to high, it's only about another 6% further lowering. So on the right-hand side, what you can see are the two different sets of goals. So 70 milligrams per deciliter, so all of the dark boxes, a proportion of patients getting to below 70, stratified by the approach used. And then the shaded boxes are the proportion of patients getting to below 55. So simply, even in this group with slightly better use of high-intensity statins, you're going from 39% overall getting to below 70 to 18% getting below 55. When we're aiming for 70, we start to do better with the use of higher intensity regimens. And then we do better still in the blue when we add in ezetimibe and a monoclonal thereafter. But when we start aiming for 55, it's near impossible to get there without combination therapy. Only 1 in 5 will get to goal with statins, another 1 in 5 with statins and ezetimibe, meaning about 50% of people will need a monoclonal or a PCSK9 directed therapy. We can look at population distributions in more detail. This is the Sweetheart Registry, so unselected, all-comers national registry. The top left-hand corner shows you the LDL distribution at admission with a myocardial infarction, and the black bar is 1.4 or 55 mg per deciliter, the goal. So we give most of these people statins, of course, and you'll see below that the population distribution moves to the left, so more people will obviously now be at goal. And on the right-hand side, you can see that the answer is not simply to up-titrate the statins, because most of our use is actually moderate or high-intensity statins. So that top right and the bottom left look fairly similar. Where you start to shift those outliers and pull them over to the left is when you add in a second drug. So a bit like our hypertension colleagues. But there's still going to be some people left over on the right. And they move over to the left when you start to add in a monoclonal. Now, the problem with combination therapies, largely with small molecules, non-communicable diseases, similarly with hypertension, is we're reliant on patience and adherence. So if you think about it, on the y-axis, what you can see is the change in cholesterol levels as a function, these are new cases of ASCVD, as a function of what a doctor prescribes, low, moderate, or high-intensity statins, and what a patient does with that. They are fully adherent or they are non-adherent. And this basically is standard methodology, 80% proportion of days covered. And you can see basically the biggest reduction in LDL occurs when we actually prescribe the right treatment, but the patient has to follow that. And it's when the two actually occur together, that's when you get the biggest LDL reduction. Any other combination, and you're not doing as well. Now, if you do the same thing now, and you're looking at hazard ratios, so compared to people not prescribed statins, the biggest reduction in risk is when patients are adherent and we're prescribing higher intensity regimens. So all other things being equal, some part of risk is going to be related to LDL lowering, which is dependent on two things: what the intensity of the regimen is and whether the patient follows that or not. So in the UK, for example, you can see that instead of the current events that we see for every 1,000 patients with ASCVD per year, which is about 72, if we had optimal prescribing and adherence, that number would fall to about 48. And if you scale that up to the level of a large population with prevalent ASCVD, that simple metric means we are basically having an excess of 12,000 cases for every 500,000 people per year. So are there other options that we might have? Well, this is basically the life cycle of the LDL receptor, and that's the main way that you lower circulating cholesterol levels in blood. So when you give a statin, and indeed when you give ezetimibe or bempedoic acid, what you're doing is you're increasing the production of the LDL receptor at the level of transcription. So you make more LDL receptors. They bind LDL particles. These are internalized. The particles are removed, cholesterol is excreted in bile, and the LDL receptor goes back to the cell surface. But the problem is there's a second protein called PCSK9. And as you diet, as you give statins, more of this is produced. It binds to the LDL receptor. Now, when this is internalized, it's destroyed. So you have less. So if you can keep the LDL receptors alive that you're manufacturing, then you can basically enhance LDL lowering. And you can do this with an approach that we've got with monoclonals, MABs. This is a bit like a bucket, catching all of the PCSK9. Or you can do it by switching off the tap. And the hepatic tap is basically what drives 70% of PCSK9 in blood. And the way we do that is at the level of the messenger RNA and shut down 70% of PCSK9 in blood. So there are two approaches for RNA-based therapies, and the big advantage are the frequency of the injection. So on the left-hand side is antisense, single strand of drug working inside the nucleus, binding to a complementary sequence of messenger RNA. This is being tested for LPA lowering right now, and basically it breaks down the message. That's the critical step between the gene and the protein. On the right-hand side is what we use, for example, with inclisiran and other therapies now that are emerging. And this basically gives us the potential for far more infrequent dosing, maybe twice a year. And this is because in the cytoplasm, we have something called the RNA-induced silencing complex. It recognizes naturally occurring sequences of double-stranded RNA, microRNAs, so we can target that. We can give it a target, in this case, message for PCSK9. So once the drug is loaded onto that complex, it seeks out a specific target and a specific target only and breaks that down under catalytic cleavage. We can reduce the volume of injection, the dose of injection, because the liver expresses something called the acyl-glycoprotein receptor. This removes senescent cells. What does it recognize? A sugar residue called GalNAc. So now knowing that, we can add that to any oligonucleotide, meaning that it's taken up straight into the liver within 4 hours and you can't measure it in blood. So we basically tested this in 3 pivotal phase 3 trials with a dosing interval of day 1, day 90, and then 6 monthly thereafter over 18 months. And we tested populations with heterozygous FH with an elevated LDL despite statins, a population with ASCVD, 1,500 patients, Orion 10, with an LDL above 70, and secondary prevention and high-risk primary prevention, and the LDL criteria are shown. So what you can see across the top are the data for the Orion 10 trial, 1,500 patients with ASCVD on the bottom, a similar trial, but in secondary prevention and primary prevention. And on the left-hand side, you can see with that infrequent dosing, we can basically lower circulating PCSK9 by 70 to 80% and maintain that. And on the right-hand side, you can see what the peak and troughs look like. So now we can think about annualized reductions in LDL, if you will, of about 50% with twice-a-year dosing through this approach. Now, this doesn't really come at the price of any major adverse events. So when you look at liver safety, when you look at CK, when you look at platelet counts, the data for inclisiran are comparable with placebo. The only thing that you see is a small excess of injection site adverse events. Familial hypercholesterolemia, this is a group of, these are a group of patients, the prevalence is 1 in 311, where they have largely a defect in the LDL receptor. And so 50% capacity, they're running on about 50% capacity because they've inherited one gene from mum or dad, meaning that the blood levels are very high from birth. On the right-hand side from our global registry of FH, you can see not only is FH detected late, but with current approaches, about 3% get to levels below 70, and we start diagnosing them age 44. So think about all the years of exposure that are missed. Now, if you basically use a statin and ezetimibe, you can upregulate the good gene, make more LDL receptors. And with a drug like inclisiran, what you will be able to potentially do is reduce PCSK9 levels and make those extra receptors live longer. So on the top right, you can see that you can almost normalize these levels of LDL, bringing them down from 150 to around about 75. The real challenges with all of these treatments is how we're going to implement them. Because with non-communicable diseases, our patients don't report symptoms, we look at numbers, they improve, and we have this wait and watch approach. And you've seen the theme of better precision medicine, decision support tools. There's a lot of complex information now that's going to be available. We also need, I haven't touched on this, but I will do tomorrow, about the fact that earlier treatment gives you actually better cumulative benefits. Meaning that, for example, it's a bit like your pension. If you start with small amounts and change your life course early, you'll actually get really much more benefits than if you were starting later, when you're going to have to put more away into your pension. We've got to be able to quantify these benefits because ultimately we're at the mercy of payers and policymakers, and we've got to have those discussions because some of these treatments are not going to be cheap. Let me show you finally a couple of slides about the difficulty with implementation. Back to Sweetheart. On the right-hand side is the absolute change in LDL cholesterol that you see in patients with myocardial infarction. And if you look at the fifth row, what you will basically see is the LDL levels at admission. 75% of people will have an LDL between 2.3 and 3.8. So they're not hypercholesterolemic, but they've had an MI. Most of these are going to be statin naive. But you can see on the bottom row, very little happens in terms of changes, and they have the worst outcomes. You've got new treatments. These are monoclonals in Europe. Where are they being used? For outliers with very high levels of LDL cholesterol. And you can see that when we use them mostly as monotherapy on the right-hand side, no drug, no matter how powerful it is going to be able to get patients to goal. We've got to think about combination therapies, which is really what's shown in the middle. And that means we've got to basically lower the reimbursement threshold. These were the LDL levels in that registry. So we've got to have these discussions about how we implement some of these tools to change population health. So new treatments need to be like blood pressure, combination therapies, and we're only going to be able to use these if we start to have sensible decisions with payers and policymakers about how we can implement them, not for outliers, but for the bulk of the population. Thank you.